It is 6 o'clock. We are starting at 6. So welcome to Medical Assistance in Death. Where is the client voice, perspectives, and viewpoints? Just a few housekeeping items. If you need to use the washrooms, they're just to the left of this space, down the hall, right immediately there. We're asking that people respect the panelists and not do any filming or take photographs. CAMH is actually going to do the filming of the panelists who've consented to be filmed in the talk. And then we'll upload that later so you'll be able to share it with other people as you wish. If you have any questions throughout the event, or if you have something you want to say and you don't feel comfortable speaking publicly yourself, we've got 3 wonderful Empowerment Council volunteers who can take your questions or help you with anything you need. Steph, Chris, if you want to just stand up so people can see who you are, they would be happy to assist you. I just want to say a quick thank you to a couple of people, including our Empowerment Council student placement, Chris Spencer, who's done a fabulous job pulling together our WordPress site, which has a collection of different perspectives on MAiD from a mental health service user perspective. I want to thank Alexandra Wilkinson, Robin Rowe, Rosalind Shields, and Michelle Warner for working with the Empowerment Council in bringing this event to fruition today. So, and of course, welcome to all of you. Thank you for coming out, even though it looks like it's going to rain. I want to say a special hello to our international friends who are here from Ireland and Manchester. Welcome. We do fun events like this all the time. In fact, I spent a good portion of my weekend ruminating on how I was going to make this a fun event. I'm determined to make this a fun event. Because without a doubt, a lot of us bring probably a lot of emotion and feeling and expertise to this topic. But having said that, there's always room for us to be present and to learn more from each other. And so hopefully we can create a space here today where we hold that and, just talk to each other and listen. Quick note about language. I understand many people in the audience may identify in a diversity of ways and use different terms to describe your experience with mental health services. For the purposes of the session today, we're going to be using the term mental illness because that was the language used in Bill C-14 and now in the MAiD legislation. We don't mean to offend or impose any definition on anyone. Please feel free to use whatever you like during the Q&A. There have been a lot of committees, a lot of working groups, forums struck to analyze the Carter decision and the subsequent rollout of the legislation. This is the first event in the jurisdiction of Canada that I'm aware of. Please let me know if somebody knows something different. That centers the voice and the standpoint of people with lived experience, psychiatric disability, etc. This really matters that we're doing that. And is there anybody here from the Council of Academies, perchance? No? Okay, well, that's good to know. One of the questions that we want people to think about as we hear from our panelists and audience is what should happen next? What do you think needs to be mobilized or organized to continue conversations with respect to MAiD so that service users facilitate the many complicated layers of the legislation as it rolls out? I'm Lucy Costa, by the way. I work at the Empowerment Council. The Empowerment Council, for those of you who may not know, is an independent nonprofit organization made up entirely of staff, board members, constituency of people who've used mental health and addiction services. The people in our organization have been there. We've been doing education, advocacy, and what is now commonly understood as patient engagement for over 25 years, right here at this site at Queen Street. While the EC does not currently have a position on MAiD, in the immediate, our concerns lie with ensuring there's opportunity for forums and safe environments for service users to get together and determine a couple of things, such as, one, as a community, what do we stand to gain through extended access to MAiD for persons with mental illness? Two, as a community, what do we stand to lose through extended access to MAiD for persons with mental illness? And three, who is missing from these conversations that we still need to engage? How are our interests and opinions as individuals, how do they relate, and how are they accountable to the overall interests of the community and its self-determination? So I'll be emceeing the event today. And to get us started, I'd like to introduce our first speaker to give us a bit of background and context about where we're starting in case some of you may be new to this conversation. So I'd like to introduce Michelle Warner. Michelle is in-house legal counsel at the Center for Addiction and Mental Health, CAMH. She received her law degree in 2004. She provides legal advice to the leadership, psychiatrists, and clinical teams of CAMH regarding mental health law. She represents the hospitals in hearings before the Ontario Review Board, the Consent to Capacity Board, in appeals to the Court of Appeal of Ontario, and in proceedings before the Ontario Court of Justice and Superior Court. Michelle regularly teaches on mental health law issues, and prior to joining CAMH in 2013, she worked as a senior associate in the health law group Bourdain, Ladner, and Gervais. So we're going to let Michelle get going. We're going to take questions also all at the end because I want to hear from Michelle, the panelists, and then we'll open it up if that's okay.
Good evening, everyone. As a lawyer who you've heard works at CAMH, I want to take this opportunity to extend a very warm welcome to all of you on behalf of CAMH. CAMH wanted to take this opportunity to partner with the Empowerment Council, as Lucy said, to create an opportunity for people with lived experience to share their viewpoints on whether MAiD ought to be available to people with a standalone mental illness. This conversation follows a prior one that we had in February, a catalytic conversation in which we heard the perspectives of professionals. Tonight, we turn our attention to those with lived experience. For those of you who are interested, a video link to that prior presentation from February can be found on CAMH's website. My presentation today is going to be a very high-level 10-minute overview of the current legal framework. And the goal here is just to make sure that we're all starting the conversation tonight from a common understanding of where we're at today in terms of the legal framework. It's necessarily high level. We only have 10 minutes to do this. It's not going to get into the nuts and bolts of the law. Just want to give you a high-level overview. I'm going to cover three broad topics. One is where we're at currently in terms of our law on MAiD. I'll talk about what's coming next. You'll hear about the legislative review. And put Canada's approach to MAiD in context in terms of what other countries and some of the states in the US are doing. So where are we at now? Canada's legal development started back in February of 2015 with the Supreme Court of Canada's decision in Carter. Many of you are well aware of this. That was the case that struck down the provisions of our criminal code that prohibited physicians from providing assisted death to patients. That was known as the Carter case, of course. The Supreme Court gave our federal government a period of time to enact new legislation that was compliant with our charter. That legislation came into effect almost a year ago now, and that legislation, formerly known as Bill C-14, made MAiD legal in Canada so long as certain criteria set out in the criminal code are met. A couple of high-level things to keep in mind in respect of how it applies to mental illness. The new legislative provisions, as you'll hear me describe in a bit more detail, do not expressly exclude the application of MAiD to people with mental illness. However, as we talk about the criteria in the next couple of slides, it appears that as they are currently framed, it's unlikely that someone who has solely a mental illness without any underlying physical illness would likely qualify. So what are the eligibility criteria? What does the law say right now? It sets out 6 criteria that a person has to meet in order to be eligible for MAiD. The first two are fairly straightforward. MAiD will not be available to people who are not residents of Canada or to anyone who is under the age of 18. There's some other fairly straightforward conditions. Person making a request has to do so voluntarily and with informed consent. They have to be capable of making that decision. We're well familiar with the assessment of people's capacity to make healthcare decisions. That has to be true of MAiD as well. What I want to draw your attention to is the grievous and irremediable medical condition requirement. So the law sets out that a person has to be suffering from a particular kind of condition in order to qualify. So I want to break that down a bit in the next slide. What does grievous and irremediable mean? The new law gives us some framework for understanding that, and it does so by way of setting out 4 components of that definition. So a person has to meet all 4 of these in order to be eligible to receive MAiD. They have to have a serious and incurable illness or condition. They have to be in an advanced state of irreversible decline in capability. Thirdly, they have to be enduring physical or psychological suffering that they themselves experience as intolerable and cannot be relieved by way of treatment or other methods that's acceptable to them. This is the subjective component of the law. And finally, the 4th criterion is that the natural death of the person from their medical circumstances has to be reasonably foreseeable. They don't necessarily need to have a prognosis of time within which their death is anticipated, but it has to be, as framed in this law, reasonably foreseeable. And it's that last criterion that makes it hard to imagine for some people how the law could apply to someone with a mental illness alone without a concomitant physical illness. Okay. That said, we all know that some people with mental illness also have an underlying physical condition, and that physical condition may render them more clearly eligible for MAiD. And sometimes in those circumstances, the issue of their mental illness may go towards the assessment of their capacity to consent to treatment, and that sometimes symptoms of mental illness may cloud their judgment with respect to treatment or their decision to take MAiD. So where do we situate ourselves in terms of other countries and other states in the United States that do MAiD? We're not alone in making MAiD legal. We're not the first country. We're not the only country. However, of those places that do offer MAiD, only 4 of them extend it explicitly to people with a mental illness alone: Belgium, Netherlands, Luxembourg, and Switzerland. Those 4 countries have legislation with much broader criteria for physician-assisted death that has opened the door for people with a sole mental illness to be eligible. So what's next? Where do we go from here? And this is where the issue of the Council of Canadian Academies review comes in. So as part of the new legislation, there is required by that legislation an independent review to be conducted by December of 2018, so within 18 months from now, a review of certain aspects of the legislation, including, as one of those, the issue of whether the applicability of this law to people with a standalone mental illness. So the task of the Council of Canadian Academies and the expert panel that it's tasked with doing this is to assess the available evidence that will inform ongoing policy discussions. This is already underway. It's already begun. And you should know that as part of this review, it is anticipated that they will be seeking input from stakeholders. So with that in mind, today is an important opportunity, of course, to start hearing more from people with lived experience with mental health issues as this CCA review process unfolds. So over to our panelists. Thank you for your time.
Thank you, Michelle. I'm now going to introduce actually all our panelists to come and take a seat up at the table. I'll start with Mark. Mark Hennick, first of all, I have to say, I really want to thank these panelists for coming today. We should give them a warm applause because it's not every day You can call up some people and say, hey, would you like to come and do a talk on medical assistance in death? So I really appreciate you guys making time to come here. So Mark Hennick is an in-demand public speaker and active media commentator on issues related to mental illness and mental health. He's currently the National Director of Strategic Initiatives for the Canadian Mental Health Association and a senior member of the Board of Directors for the Mental Health Commission of Canada. Mark, if you could come up and take a seat. Graham Bayliss is a writer, a digital editor at TVO, and a former managing editor of The Walrus. Thank you. And Lisa Walter is a visual artist and educator and has also worked as a playwright, designer, journalist. She's spoken in public many times about mental illness and the arts and has presented at major conferences regarding service users, co-teaching with service providers. So thanks. So to get us started, we're going to start with Mark, and like I said before, we'll take questions at the end.
Alrighty. Thank you, Lucy. Have we given Lucy a round of applause yet? So thank you for having us to an important conversation, especially focusing in on the service user aspect of this and people who have been through the system, because one of the most frustrating things for me, I think, when I first started paying close attention to this debate has been it's a debate with all kinds of lawyers, no offense, and bioethicists and professors and physicians, but less so with people who have actually been there, who have lived with these things. So, you know, that's what drew me into the conversation to begin with. My context with this starts really as a child, having or being presently a person who's lived with depression and anxiety for longer than I haven't, and being fortunate enough, I would say, to have experienced the full range of what that means. I mean, there's lots of people in the room that know what I mean. You know, from your average everyday 6 months of dysthymia that you can't, you know, quite seem to shake it off, to the soul-crushing major depression that makes you not want to live anymore. As a teenager, I spent lots of time through the revolving door of emergency rooms with my own suicide attempts, escalating in nature. It turns out you're not born just knowing how to die. You figure that out as you try a bunch of times, and without a service system to really help you in a meaningful way in the community, then you don't really learn the coping skills that you do have, in fact, other options. All of that history brings, I bring all of that history into this debate where I consider the experience of the debate about medical assistance in dying, and especially exclusively for people with mental illnesses, as something that just doesn't make sense for me in terms of my both experience with the mental health care system from a service user perspective, but then also later as a clinician and as an advocate and somebody who's had to navigate the system from both sides. Somebody who's tried to navigate it from the perspective or through the fog of depression, and then somebody who's tried to help other people navigate it through the same struggle. What I bring to that is that it doesn't make sense to me, or how I could summarize it is, it doesn't make sense to me for physicians, people who are supposed to help, and as a system in general, to say that, you know, we're going to help you die, but we're not going to help you to recover or to live. Because that was my experience with the system, with the mental health care system, that most of the time, people who get to that place where they want to die because of their mental illness, because of their depression, and I say I'll use that example a lot, but there's, of course, all kinds of examples that you could use. But severe and persistent depression, which is, according to the World Health Organization, as disabling as quadriplegia. So we're not talking about people not suffering. That's not the, you know, people with these struggles often suffer more than more visible, more tangible illnesses. But how they get there is different. The depression itself, believe it or not, even though it feels like it won't kill you. The schizophrenia won't kill you. The eating disorder, while it has the highest mortality rate of all mental illnesses, the mental disorder on its own isn't what actually kills you. What kills you, I believe, are the holes in the system that prevent people from getting help. That when you show up, by the time you get to become suicidal to begin with, the suicide prevention strategy in our society right now is to line up the ambulances at the bottom of the bridge, not stop people way upstream from getting to the bridge in the first place, which is how we know you prevent suicide. Educate people about the signs and symptoms early on, or earlier on about that than that. educate people on how to name and label their emotions and actually deal with those emotions, to help protect them in their society, in providing them housing and employment and reasons to stay, reasons to live. But we're still failing to do that, I think. We're still treating these types of illnesses as irremediable. And I think that, you know, a friend of mine, Dr. Heather Stewart out at Queen's University, who does quite a lot of research on stigma, likes to say that when we bang the drum of biological determinism too hard, that's what embeds stigma even further. In other words, when we keep harping on the idea that these are brain disorders, and we do know there's all kinds of physiological correlates for mental illnesses, the verdict is kind of out on that. We have decades of research on that. But when that's the only perspective that we bring, people start to think that their brain is broken, that they have these illnesses, therefore, you know, it's a brain disorder and there's nothing we can do about it because we can't fix the brain. First of all, that's not true. There's lots of things that we can do to help people's brain. But second of all, we know that there's all kinds of aspects of mental illness that aren't brain-based, that aren't biologically based, including some of them that I mentioned before. So my real issue with the debate that the legislation or the proposed changes to the legislation, and I do think where they've landed, where the government has landed presently, is a well-measured approach in terms of the safeguards in place. Mental illness shouldn't be a disqualifying factor for people who have other terminal, irremediable illnesses. But on its own, we're failing those people who would come to the point where they no longer want to live, that they would want to access medical assistance in dying. From my experience as a clinician, my fairly brief experience as a clinician, what I've noticed as well is that when processes like this come into place, or not quite like this, but any kind of process comes into place in the medical system where there's already embedded stigma against people with mental illnesses, and I get that part too, from a workplace mental health perspective. Clients become files that you need to get through so you can get home to your kids and have dinner. So, you know, I get that piece of it, but unfortunately, when you're considering somebody who has this kind of struggling and this kind of pain, it doesn't give them 15 minutes for a med review and prescription renewal, doesn't give them the time they need to really understand where they've come from and how they've gotten there. So my concern would be that, and I mentioned to Lucy, I don't like the slippery slope argument, but my fear here is that it would become that. I want to make clear too, though, that this is not to say that, first of all, I've mentioned that people do suffer from mental illnesses, very often more so than many physical illnesses. But also, suicide presently isn't illegal anyway. It hasn't been illegal since the 70s. 1973, I think it was removed from the Criminal Code of Canada. So that means that it's not a criminal act anyway to die by suicide. It's a public health crisis. It's a medical crisis that we need to address, but it's not a crime. However, when you're asking somebody else to do it with you or for you, then that is crossing over into somebody else's rights and into somebody else's freedom to object and the ethics of their own profession too. So, you know, I think that certainly from many of my colleagues and contemporaries and other people with lived experience who are active in this field disagree, certainly with this perspective, that they feel that it is their right to have somebody to end their life for them. And my final point on that would be that I think that we need to discriminate between capacity to make a decision and the inevitable effects that your condition has on your way of thinking. So somebody with a mental health problem or illness, most of the time, I don't know how many, there's probably a lot of people in the room who have seen how the high bar it is to actually lose capacity. And you've worked, Michelle, with the Consent and Capacity Board, I heard. So it's not easy to take away, thankfully, people's rights anymore, which is nice. We've come a long way. However, that's very different. Losing capacity because of your mental illness, well, that's a very high bar. Almost everybody changes the types of decision they make based on the experience that they have. So when you have depression, you make different decisions. You see your life differently. And unfortunately, death is one of those preoccupations. Whether or not you're suicidal, you're more likely to think about death than if you didn't have depression. So I think it's very difficult, even if you have full capacity, to be able to make that kind of informed decision, because that's one of the features of depression anyway, is to think about death, to feel that it's hopeless, to think you could never get out of it. When I was 15 and standing on the edge of a bridge ready to let go until some stranger pulled me off, I wouldn't have believed me if I had told myself that all these years later I'd be able to do everything that I've done and become who I've become and have a family and have a great job and do what I love to do. I wouldn't have believed me. But I'm thankful that somebody else did pull me back, that they did convince me, if not in that moment, then just by sheer dragging myself through the next couple of decades of my life. I'm glad that happened, and I hope that other people have that opportunity too, to be able to live, to thrive, and to actually get the support and services that they need in the community. I don't know if that was close to my time or not, but 1 minute left. So questions, answer, no. So I'll cede my 1 minute to the gentleman to my right.
Thank you. Good evening, everyone. Thanks for having me here. I'm not a particularly adept public speaker, and I tend to talk pretty fast when I'm nervous, so with any luck, this will be mercifully short. You'll also have to forgive me for reading from my phone instead of a piece of paper. The fact is, we've come far enough as a society to talk openly about medical assistance in dying, but we still can't seem to build a reliable printer. So I'm a journalist, and not at all a medical professional. But I think particularly as a journalist, I'm uniquely unqualified to talk about any of this stuff because I haven't studied it in any way. I've only lived some of it. And so the only things I'm going to talk about are those that pertain to depression or anxiety or OCD, which are the things that I've dealt with. And for the rest of the time, I will be sticking to the script. I'm here because a little more than a year ago, I wrote a magazine article about Canada's right to die legislation, making the argument that assisted suicide should be made available to the mentally ill. The article was, to some extent, self-serving. I was in the middle of the worst depression I'd experienced since being diagnosed when I was 17, and I was hoping government would make a peaceful and mess-free way out available for people like me. For some reason, just to know that the option to die existed would have made living a little bit easier. I can't explain why, but perhaps some of you will know what I mean. I'm doing a lot better these days, and I'm glad I'm still here, but I remain firm in my conviction that the suicidally depressed should have the right to end their suffering with medical assistance when all other options are exhausted. The reasons have to do with high-flown concepts like dignity and humanity, but speaking in practical terms, it's easier on the depressed person not to have to choose some grisly method of annihilation, and it's easier on that person's family not to have to find their loved one's body swinging from a rope or see their blood splattered on the floor. Admittedly, I'm not sure what the process would look like. I imagine assisted dying services would be limited to those 18 and older, because if they're old enough to join the military and potentially take someone else's life, they're old enough to take their own. And I imagine the patient's case would be reviewed by a panel of psychologists and or psychiatrists and or physicians, and then only after all reasonable medical and therapeutic interventions have been tried. I'm not suggesting doctors start unilaterally prescribing bye-bye pills to patients who feel a bit blue. I'm suggesting we give those with interminable mental illness the same dignity we give those with terminal physical ailments. Of course, there are plenty of mostly annoying arguments against expanding medical assistance in dying, some to do with slippery slopes, others to do with Jesus. But the one that bothers me most is the one that says the mentally ill are inherently incapable of deciding rationally to kill themselves. As one Conservative MP said last year, at what point does someone suffering from a mental illness offer his or her full and complete consent? It's impossible. Consider the catch-22 this idea creates. If you don't want to live, then you can't possibly consent to die. What dignity is there in trapping people this way? I haven't written about my condition or the legislation since last April, and outside my psychiatrist's office and a few radio appearances, haven't spoken about it at all. I figured tonight would be a good chance to share my thoughts on the subject at length. But it occurred to me that, being a journalist, I can do that whenever I want. Not every suicidal person has the same access to media outlets that I do. So instead of sharing my own thoughts, I'd like to share those of a few of the dozens of people who wrote me after I published my article, who might not otherwise have a chance to be heard. I've edited out identifying details in order to keep things anonymous. Dear Graham, thank you for speaking for those who share your condition and are voiceless at this time. I felt like you were reading my mind. I believe that having the dying with dignity option available would stop the obsession with suicide and suicidal thoughts, simply because we would know the other option is there. It would take away the need to find an alternative, and by the time we filled the papers and made the arrangements, we would maybe be well enough not to go through with it. Dear Graham, I'm on the same page as you in a lot of ways. I had a similar experience with thinking about death and meditating on life, only to realize I still had a few things left to finish and to keep track of. I'm biased, but I think I'm a little more in agreement with you than with the doctors who responded to your story. My backup is to get Belgian residency and hope to get it done there. Dear Graham, as you note, our options when suicidal are ugly. Any one of the means by which we might choose to leave life will emotionally disfigure our loved ones. I believe that many of us, if able to avail ourselves of physician-assisted suicide, will not. The mere existence of a gentler option will have a transformative impact on the depressive's perception. I would feel less trapped and therefore less depressed if I had the assisted suicide option. Dear Graham, it becomes so tiresome when I am told this will pass, things will get better. Even if they do, I know that it won't be long before my mood disorder will strike again and I will have to endure misery and loneliness. I've been diagnosed with major depressive disorder, and I'm currently under the care of a psychiatrist at a hospital in Toronto. I'm 59 and have been ill since I was 16. I have been prescribed innumerable medications. I've had multiple hospitalizations. I've had RTMS and ECT, and now my psychiatrist would like me to try cannabidiol, which I am loath to do. I ask him all the time about the likelihood of physician-assisted death being available for someone like me, but he assures me that things will get better. I ponder if I were to move to Belgium or the Netherlands, whether I could, in time, become eligible for euthanasia. I'm a psychiatrist, and I have not been able to work since my husband died 10 years ago. It was a struggle when he was alive, but he was a great support, and I managed. Anyway, I don't want to bore you with details. I'm not really sure why I'm writing. It's just that I've lived all the life I want to live and would like to exit with some dignity and planning to spare my family the mess and work that taking my own life would involve. These are not the disjointed ramblings of deranged minds. They're lucid and thoughtful pleas for understanding, and I hope everyone here will heed them. Because I think it really is tough, no matter who you are or what letters follow your name, to grasp the peculiar rationality that can lead someone to take their own life, unless you've experienced it yourself. And even then, it's hard to express. The last time I spoke publicly about suicide, I embarrassed myself on national radio with a truly cringeworthy description of what led me to consider it. I'm resolved not to make that mistake again, so instead I'll leave you with this passage from the novel Infinite Jest. The so-called psychotically depressed person who tries to kill herself doesn't do so out of hopelessness or any abstract conviction that life's assets and debits do not square, and surely not because death seems suddenly appealing. The person in whom its invisible agony reaches a certain unendurable level will kill herself the same way a trapped person will eventually jump from the window of a burning high-rise. Make no mistake about people who leap from burning windows. Their terror of falling from a great height is still just as great as it would be for you or me standing speculatively at the same window just checking out the view, i.e., the fear of falling remains a constant. The variable here is the other terror, the fire's flames. When the flames get close enough, falling to death becomes the slightly less terrible of the two terrors. It's not desiring the fall, it's terror of the flames. And yet nobody down on the sidewalk looking up and yelling don't and hang on can understand the jump, not really. You'd have to personally have been trapped and felt flames to really understand a terror way beyond falling. Thank you for listening.
Hello. I just had a moment of thinking of Laurie Anderson. I think in one of her albums she said something like, "Welcome to difficult listening hour." Hello, my name's Lisa, and before I launch into my diatribe, I would just like to take a moment to acknowledge that there's a lot of emotion in the room. I can sense that some people are in a lot of distress, and I think my own is just kind of bubbling under the surface. And I have a personal conviction that emotion plays an important role in this conversation. I don't think we can let it lead us by the nose, but I think there are people out there who would like to say that we have to make a rational decision and that somehow emotion can't play a role in that. But I feel that we'd be really ignoring the elephant in the room to suggest that emotion doesn't play a role in this conversation. Having said that, I believe that people who experience severe, unremitting psychological suffering, and for whom there is no reasonable reason to believe this will ever change, should have access to medical assistance in ending their lives. There's a lot of nuance to this issue, and I'm not going to have time to I think really delve into this matter as much as I would like or anyone would really like, but there it is. So I'd like to start with some of my own experience and build on that. I think it's exquisitely painful to think about people killing themselves. I myself have been repeatedly deeply affected by this issue, as have my family and friends. I myself have had periods of severe depression, social anxiety, borderline personality disorder, on and off since I was about 13. The worst of these was between 2007 and 2013 when I also had severe obsessive compulsive disorder, or OCD, as well. In that time, it wasn't the first time, but in that time specifically, I made a number of attempts on my life, including 2 that were meticulously planned, and I think it's safe to say that it's a small miracle that I'm alive today. At last count, looking at it from a slightly different perspective, 8 people in my life have killed themselves, including coworkers, 2 very dear friends, my ex-partner, and my brother. My parents and I are very, very close. After my brother jumped off a bridge in 1994, I saw firsthand how it devastated them. In addition to my own grief, I grieved for what my parents were going through. But to give you an idea of how much I was suffering when I was in the grip of OCD, I'll tell you, I would have put my parents through that a second time by killing myself. Even knowing that it would destroy the last years of their life, I would have done it, and I tried to. Both times I left suicide notes, I begged them to forgive me because I knew that they wouldn't want their child to suffer as much as I was suffering. Now, even then, I suspected that my mind was blowing certain kinds of thoughts out of proportion. But that was irrelevant because knowing that didn't alter how I felt. A friend of mine is a video collage artist. Her name's Catherine Jones. And she said something very simple in a powerful animated video she made called My Bones Bleached White. You can find that on her website. In the video, she describes a time when she was being questioned by a nurse at an emergency department, and I'm going to quote from the video. He asks, "Have you set a date?" "Thing is, I am already dead. The date is just a formality. They tell me that depression lies. It's the only language I'm fluent in." And it's that last phrase that, for me, it's the only language I'm fluent in, that particularly resonates. When we judge that someone's suffering isn't valid because it's not based on our perception of reality, I think we're failing in empathy. And by empathy, I don't mean imagining how I would feel in another person's situation. I mean what I imagine that person is feeling in their situation. And I think in our culture, in our society, we have very definitive ideas about what kind of suffering is worthy of our compassion, and they're often politicized ideas. So, for instance, feeling great suffering because because someone close to you has died or been murdered, that's worthy of compassion. But on the other hand, suffering because I believe that I'm a child molester when I'm really not, is not worthy of compassion, at least not the kind of compassion that produces change. So for all the talk, I think nowadays, on person-centered care or patient-centered care, I think healthcare providers and policymakers are falling really short when it comes to radically understanding their patients, to really accepting what they say. There's a vast amount of inequity for people who have mental illness, and this complicates any discussion about whether we should have access to medical assistance in dying. And there's no doubt in my mind that people with mental illness, people who have been psychiatricized, are second-class citizens in this country. And that is doubly true if you are a member of an Indigenous nation, a person of color, or a person with an evident disability. So I find it really incredible in the sense of it makes me incredulous to know that the surest way for people with profound psychological suffering to get relief is not through social support and healthcare, but by ending their lives. To me, this gaping inequity is a healthcare. To me, this gaping inequity in healthcare is a crisis. Since 2014, I've been working on different projects involving mental health service users, co-teaching with service providers to service providers. Having been severely traumatized by people entrusted with my care, I wanted to make change right at the root of the problem. And what I've seen there is that ignorance, contempt, and discriminatory thinking are deeply entrenched among providers. Quite a bit of their rhetoric has been internalized by service users themselves. The implications of this, as far as I can see, is that this system, which actually makes some people, as in myself sometimes, more sick, is going to be with us for quite a while yet. Some disability advocates are angered at the idea that government pretty much refuses to redesign or even fund our system, but might make it easier for service users to kill themselves. They say that if you can't get adequate treatment or support, then having the option of assisted death is really no option at all. And I'm sympathetic to that, very sympathetic. But the other side of the question is it really fair to expect those who are suffering profound psychological distress to continue suffering until we've sorted it all out? To me, that'd be like holding them hostage while we duke it out with the establishment. And this idea is even more troubling to me because I don't believe all psychological suffering can be alleviated by treatment. I know people who have tried all treatments available to them in Canada and abroad, conventional and non-conventional, without relief. ECT, RTMS, medication, surgery, I mean, you name it. And they haven't gotten better. They've tried. As passionately as I believe in the ability of people to heal from really grievous situations, I think it's wishful thinking to say that everyone who experiences profound psychological suffering can get past it. Furthermore, the illness model itself is problematic. For example, healthcare professionals have a very poor understanding of the impacts of trauma on a person's psyche. I don't know if we can even really fairly determine whether distress in response to trauma is actually an illness or a very sane response, a sensible response, to something horrible. I'm not saying the medical model is useless or wrong. I've benefited from it myself to some degree. But what I'm saying is that the model is deeply problematic and shuts out the voices of survivors. This, despite the fact that many survivors and groups of survivors have developed their own methods for living well. For these reasons, I think it inherently reproduces bias against people who are deemed to be mentally ill. For me, the crux of it is this. I fundamentally believe that even people who aren't legally competent have an understanding of their suffering, much better than the understanding of healthcare providers and policymakers and legislators. And that might seem obvious to most of us in the room, but many of us have been treated by providers as if that's not true. When I was in hospital, staff often treated me as if I was completely insensible, even when I could speak rationally and with insight into my condition. They didn't seem to realize that I could see their bullying, contempt, or indifference for what it was. To them, I was just crazy. Because we are uniquely alive to our own suffering, I believe we have an inherent right to medical assistance in ending our lives. Compare us to people with Huntington's disease. Published guidelines emphasize that people with Huntington's have the right to medical assistance in dying, even when their suffering is mainly psychological, if all treatments have failed and they are in a state of irreversible decline. When my OCD was at its worst, I believe I would have fit those criteria because I promised myself that if residential treatment didn't work, I would end my life. So my death was predictable, even if my mind was responsible for that and not my body. A significant number of people who have severe psychological suffering end their lives. It's not surprising that they do this. It's predictable. And as it is now, the way that people have to end their lives has terrible consequences. It means that we die alone, without having the ability to say goodbye to our loved ones and to help them understand our actions. It leaves the survivors, and I include healthcare providers, with terrible guilt, anguish, and unanswered questions. It means that our bodies are sometimes found after serious decomposition or having been eaten by animals, as happened to a friend of mine. Our deaths traumatize train and subway conductors and the people who find our bodies. And sometimes we don't actually die, but are left with serious disability and brain injury. We don't deserve this, and our families don't deserve this. I don't think medical assistance in dying won't mean that every life ended. Let me start again. I don't think that medical assistance in dying won't mean that every life ended because of psychological suffering isn't a tragedy. But it might mean that it won't compound tragedy with degradation and injustice. Thank you.
Well, here we are at sea together. That was incredible. Thank you so much again. I'm sure everybody is blown away. I just wanted to mention before we get into Q&A that if you need a break, there's just a little door over here you can open up to get some air. There's an exit that way if you need to get out from the back of the room. Just offering that to people if you need some space or to stretch out. So we're going to do Q&A now, and I think the goal for the next 25 minutes or so is to get as many voices as possible and a circle of voices to ask questions. Would anybody like to be the first one? I'll go right here since I'm right here.
Wow. I'm absolutely, like, Lisa, you're telling my story about bullying and abuse within a system. I've been out of it for years, but still the bullying and stigma continues. And I often play this little dance in my mind about, like, do I want to die or not? And I definitely know I do not want to die. I wish there was a way to stop the stigma and the dismissals by the medical system, especially once you've been labeled. It's impossible to get rid of it. 4 of my doctors lost their license to practice. I'll leave it at that. But the most important thing that was such a relief tonight was to hear, is it Mark at the end? Mark say as well that he doesn't support medical assistance in dying. I was one that tried to take my life. I probably matched Ashley Smith as far as my reactions to the bullying and the negativity that came from a system. I had one of our doctors, I spent 22 years in mental health that I shouldn't have been in there. But what I will say is the best part is I've been out of it now for 19 years. I've enjoyed life. I have lots of volunteer jobs. I have lots of activities I go to. I live alone. I'm very alone and isolated, but yet I have a life. And I will never, ever go back to a system that persecuted me like it did. I would love to support a stronger voice towards the supports for people to give them a quality of life that they deserve. And I think every person here has spoken about that part where we need more of the focus on what do people need to help promote healing, as opposed to focusing on a chemical or medical model that may not be the right answer. And how do we promote more listening? So I just want to thank every one of you. Thank you so much.
Thank you. Do any of you want to comment on that or keep going? Another question?
I'm not sure if you would be able to answer this. Maybe the lawyer who first spoke would be able to answer this. But what kind of therapies would they consider as you having tried before before it would be okay to say that this person can receive medical assistance in dying? Because it seems like the system offers a lot of medication, but less, like the waiting list for like psychotherapy and counseling and like the other therapies that are out there for people with mental illness is much harder to get at and much more expensive. So what kind of therapies do you think that they would consider before they allowed you to receive medical assistance in dying?
Maybe one of the panelists can start, because I think part of what I heard is some people try an abundance of different treatments. Already, but is there a question about should there be like a specific trajectory of how many things are tried before someone be considered for MAiD?
So I'm not sure what the legal or what the law says on that question and I don't think that's actually present in there, my understanding anyway. But in my experience, generally speaking, when you feel like you've tried everything, you probably haven't had access to everything. that most people in Canada don't have access to psychotherapy, even though that we know that it works for most mental health problems and illnesses, and very often it works better than medication does. But if you're unemployed, or even if you're reasonably well employed, you're still not going to be able to afford $200 an hour once a week for a year. So it's generally speaking not accessible. You mentioned psychiatry as well, of course. Wait times for psychiatry, even in downtown Toronto, where there's more psychiatrists per capita than anywhere else in Canada. That should surprise nobody, especially here at CAMH. But even here in downtown Toronto, it's 12 to 18 months to get in for regular treatment with a psychiatrist, and then you're still looking at your 15-minute appointments. So, you know, in terms of the type, and then I'll mention as well, access to psychiatric medications is not equal either. The Common Drug Review process has rejected 100% of antidepressants over the last 7 years because, these other ones here pretty much do the same thing, despite the fact that these medications have been found safe by Health Canada, but they're still not on public formularies. So there's massive inequalities in the system such that I can say with a pretty good degree of certainty that people probably haven't had the opportunity to try everything, but it does feel like it.
I can't speak to the legal aspect of it in relation to medical assistance in dying, but I can tell you that it took me 4 years to be diagnosed with obsessive compulsive disorder, despite the fact that I spent a great deal of time in CAMH, at certain times, like more times of a year in than out. And that when I was finally diagnosed with obsessive compulsive disorder, it took me 2 years of further trying treatments and suffering and trying to kill myself before OHIP finally agreed to pay for me to go for residential treatment in the United States. So if that's the bar just to get treatment, I don't know what it is to actually to get assistance in dying, if such a thing were even possible right now, which it doesn't sound like it is. But I tried probably at least a dozen different medications. I tried group cognitive behavioral therapy. I tried ECT, like lots of different kinds of psychotherapies. I failed pretty miserably at most of them. And I have to say that in terms of medication, they pretty much, the best medication I had didn't do anything, and then the worst ones made me want to kill myself even more. So I think the bar would be, I can only imagine that the bar would be very high, because first you'd have to convince the psychiatrists.
I mean, we're setting the bar here at what point it just determined that someone has tried everything. Perhaps we should be asking people who are mentally ill when they feel they've tried enough. It seems to me that, thank you. It seems to me that, you know, last year when I was going through a bit of an episode, and I ended up getting out of it, it was because I determined of my own volition that there were a couple of other things I wanted to try, and these ended up being relatively successful. But for someone who has tried a lot of things, who's spent years trying to get better, I don't know that we have the right to tell these people that they must hold on because something, sometime in the sort of nebulous future might work. Strikes me as something that's sort of inhumane.
So my question is a little bit related to the last one, and it goes back to the lawyer's presentation about euthanasia. Let me just open my phone. Okay, so point 3 on the slide for grievous medical conditions said that individuals who have a terminal illness do not have to accept treatment options that are advised to them. So I'm wondering, is this a sort of policy we can translate to medical assistance in dying for those with mental illness?
Michelle, do you want to try to answer that question? Do you want a mic?
It doesn't not apply to mental illness. So this criteria, so as you've just described, sorry, I can't see who asked the question, but would apply to someone with a sole mental illness, is enduring physical or psychological suffering that is intolerable to them and that cannot be relieved in ways that are acceptable to them. That's all the law says. So I read that as saying that any person, whether they have a mental illness alone or coupled with some other physical illness or physical illness alone, is not required to accept treatment that they themselves consider unacceptable for them. I don't see that as a limiting factor in respect of mental illness specifically. However, it might be worth thinking a little bit about the informed consent criteria. Remember we talked earlier in my presentation that one of the eligibility criteria for MAiD is the person has to be giving informed consent after being informed of all other available treatments and care. So it may be the case that a person deciding not to accept a particular form of treatment for their mental illness, we'd want to make sure that they meet that criteria as having been informed about those options and that they're making an informed and capable decision not to accept some or accept others or accept none.
Any other questions? Anybody else? I want to give everybody a chance. I just wanted to mention, too, that we have this question for the audience, if you wanted to answer it, and then also wanted to get people to think about how you see other issues related to the legislation and the rollout of the legislation as relevant to service user community. So, for example, how should the government keep statistics or track requests? How should hospitals like CAMH engage with people who make requests, and what are the complexities of that, given that people come into the hospital usually because they're depressed or they're already thinking about suicide? Like, how does that navigated? So wanted to get people thinking about that too, and also thinking about the future. What should service users do? Should we just leave it all to the clinicians and legal experts, or should we continue to organize? I'm just planting seeds.
I'm just wondering if we know at all what it looks like in, was it Norway, Belgium? I can't remember the exact countries where this does exist. Do we know does anyone know what that looks like, or what the ramifications have been, or I don't know how long it's been going on for, what the criteria are, anything like that?
Anybody who's comfortable speaking to that question?
So there are statistics available from a number of countries, and forgive me, I don't know them offhand, but it is fairly widely used by a range of mental health diagnoses, including eating disorders, anxiety, depression, postpartum depression, and then branching out into autism and developmental and genetic disorders as well. So, you know, grief was another one that it was used for. An elderly woman whose husband had passed on account of her grief and bereavement chose to opt to die. So it's really quite a mixed bag. Yeah.
There's a question here.
Sure. Just to add a bit more to that question.
I just think it's also important to remember that when we get the information from other countries or even from our own country about the stories behind people who've requested this, we're typically very often working with exceptionally limited information. And it's only when you either get the family who got the blessing of the person to share the story, or the person themselves before they die, who gives you a fuller picture of what exactly has led them to make this request. If you rely on simple diagnoses, or even, as has been done in the past, a review of the summary statements after this has happened in a mandatory report, you get this tiny, tiny little bit of a snapshot of what's probably an infinitely larger story of this person's whole life, and the level of support they've had or haven't had from healthcare services. So it's very difficult to draw conclusions from that. And that's where I think that because we're starting this in Canada, we haven't done it very well with the initial rollout of what is available as far as MAiD goes. But we should be doing it now we should be monitoring all of this and reporting on this in a far more detailed and meaningful way than we are, and especially if we consider extending it to any other groups like under 18s or by advance requests as well, because you just don't get the fulsome story. You can't understand it with simple ideas, stats.
Well, I was thinking that we're probably looking at this too narrowly. I would want to look at it in terms of what's happening in society, and that more and more people are spending time alone because of the way people end up living alone, and such, families aren't as cohesive as they used to be. And so in that kind of world, which is not going to go away very quickly, there's not enough options, and people who don't want to live alone don't have places to live together. There's not enough places to just go and be. Like when I was going through depression, I wanted to have a place where I could just be and not have to organize anything, do anything, just be. And there's we need places where people can be looked after for a while. And we need options like physical, massage and all kinds of wonderful things that could help people feel better. I'm just thinking that we're just looking at it too narrowly. I think we should put a lot more money into investing in options. And I know they've worked in other places, and I don't know the specifics, but I know they used to have houses where people could just be. I don't know if they have ever had them here, like a safe house. Anyways, just thinking more broadly, would make a big difference. We obviously aren't serious enough about helping people, because otherwise we would put money into therapy and giving people a chance to have psychotherapy rather than going to a psychiatrist for 15 minutes. That's obviously number one thing. I mean, we're not putting enough money into things that are important. And when you have to pay $150 to see a therapist, that's not good. It doesn't help.
Okay, we have a question on this side of the room. I'm just going to give everybody a chance. We're happy to go back to you two. I just want to give a circle of voices.
Hi. Hi, my name is Ellie, and I'm not a professional person. I'm a service user, I think they call them now. I have been surprised at the way that I've reacted tonight to this loving group of people, and people who have exceptional amounts of education and wealth of knowledge. I won't go into my story because I would take half an hour, but I have to say that it was one social worker right here at CAMH who basically reignited my spark, because I believe that all things want to live. I think to get to the point where a person wants to die is a tremendous tragedy, and I have witnessed many people who have fallen through the cracks, so to speak. I agree with this lady. I've been on a disability pension for my life. I have been diagnosed with epilepsy because of having brain injury from being beaten a lot. I lived in the streets. I had a drug addiction. I got in trouble with the law. Yada, yada, yada. But there was one lady here who turned me on to some programs that helped me a lot. But she basically spent time with me just saying that I was worth it, and that I deserved to live, and that she got me talking about wanting to live again, and living in a very meaningful way, where someone like me who'd been on a disability, and even though I have education and I can think well in spite of my seizures, I have something to give. I have a place in society. I have a purpose here. And I'm going to start to bawl my head off, so I'm going to give it back to Lucy. But thank you so much for listening to me, because there's a lot of people out there like me who don't feel like they have a voice, and that's why they get into the things they get into, which aren't helpful to them.
Thank you. keeping in line with giving everybody a chance to speak, I'm going to pass it to Joanne.
If we think of MAiD as on the continuum of a mental health service, and I know that may be controversial for some people, I would be interested, especially from the last two speakers, what we need to have in place in order to ensure that there's equity in accessing this choice, because we know there isn't enough healthcare services, and there is inequity based on people's, who they are, race, class, etc. So I could imagine that, like someone who presents as a middle-class person and who can articulate things in a particular way could make the case that they should be given this option over someone else who communicates in a different way. So since the two of you think that it should be available to our community, what needs to be put in place to ensure that everyone who wants to access it can?
Well, as a straight, white, middle-class male, I'm pretty much exactly the kind of person you're talking about. And so, yeah, I reckon I could probably make a pretty good case. But I think what I would like is, you mentioned the idea of it being a continuum, right? Like just one type of, so to speak, treatment on the continuum. I think what I'm saying is not that this should be made specially available, but rather that, we should ideally be funding all manner of different treatments, including this one. So I think you're talking about like a different sort of issue, which is how do we get mental health treatment more widely available to everyone in the country. What I'm saying is that I want medical assistance in dying to be part of that spectrum of treatment, to be part of the funding, that sort of thing. I just think it needs to be sort of included, and we need to fund, we need to fund everything. It often comes up, and it's something that comes up in politics a lot, the notion that if you want to fund one thing, you therefore don't want to fund the other. What I'm suggesting is that we fund all manner of different treatments, including medical assistance in death. That's my view.
It's a very complex question, and I want to echo what Graham has said, because I think you said it very well, Graham. The idea that it's not just assistance in dying that needs to be made equitable, but mental health care in general. I mean, even when we look at the people whose voices are privileged in this conversation, a majority of people in the room here are white, and I myself am white and well, not middle class, but very articulate, and all three of us are white. And so there's, and when we're looking at people with intellectual disabilities in particular, I think there's the best thing that I can point to is that we need to be really involving people much more on a much deeper level, on a much more equitable level. We really need to be finding people who are articulate. See, even that is a kind of privilege, so I'm going to take that back. But we need to be directing our support towards people who can play a role in identifying the needs of community members and involving them not just in terms of accessing this particular treatment, but broadening our understanding. Different communities have different understanding of what a mental illness is, or even if it is an illness at all. How do we work with people who, how do we support people who have what we refer to in mainstream conventional society as an illness? And I think it really means privileging people who can assist us to understand this, because we're failing a lot of people. There are a lot of very marginalized people who are being failed on so much more than I in particular was being failed. And on the whole, it means that we need to, I don't know, I struggle with that question a great deal, because I don't think the system even begins to grapple with the idea that our voices are even worthy of including in a conversation in a meaningful way. I mean, just the fact that the Council of Academics, Canadian academics, are the ones who are making this decision, and that we're having this conversation kind of as an afterthought. Oh, and they might want our comments later on. That's great. But we're really on the margins of this conversation. And this is a conversation about my life, about our lives, and more importantly, about the lives of many, many people who can't be here tonight or didn't choose to be here tonight. So, I think that is a really big nut that needs to be cracked, and all the pieces need to be looked at very carefully. And I'm going to be a bit blunt and say, we don't have to reinvent the wheel on this. There's lots of good work in the community that's been done about these kinds of things, but we have this habit of forgetting that it's out there. We're not funding organizations that need to be funding, that are doing cutting edge work on this kind of thing. We're not recognizing the work that they put into this. We're not building up those communities. We're willfully forgetting them. And so if we want to take this question seriously, we need to go and look at the work that's already been done and not pretending that it hasn't been, that this question hasn't been examined. I mean, I was at a conference in November 2015 called Where's the Patient Voice in Education? And some of the most articulate people who were there were people from a group with intellectual disabilities. And they spoke very articulately about how marginalized they are as patient advocates. And it's giving me goosebumps right now, even because they had so much strength, but they are, I think, willfully overlooked. And I just find that so fundamentally wrong. So I think we really need to do a lot of soul searching in that department. And I think we've been failing miserably at it. Not to be, I mean, I know my words are harsh and they're kind of passionate, but it's really frustrating to hear from people who have done the work and who are still not being heard. Thanks.
Hear, hear. Very good. We'll take the next question. If you're feeling hot, I just want to validate. I don't know what is going on with the air conditioning, but yes, I'm feeling hot. Feel free to grab some water, replenish yourself. We're doing great. Nobody's attacked anybody. I'll pass on to the next one.
Yeah, so what I'm hearing is that there's plenty of ways that people can communicate that they want to die. It's just a matter of who is actually receptive to these messages and who is listening. And I'm thinking about, a lot of the invisible kinds of work that social workers do, and then thinking about, how we are not funding therapists, and how a lot of that kind of work has a spiritual component to it. When you think about individuals doing, one-on-one communication, saying you have value, doing that empowering work. So my question is, what do you think about our current system and how a lot of what's not being funded also has a spiritual component to it? Can you speak to that?
Sorry, can you just define exactly what you mean by spiritual?
Yeah, exactly. I think that's kind of where I'm going with it, in trying to have a discussion on what do we actually define as spiritual or not, and how that's very much so up to the individual, and how even just like, for instance, going on a unit, a client asked a peer support worker, how are you working right now? Like, did you see a witch doctor? Right? Like these kinds of conversations about what happened in your recovery, how did you get to where you are, and what helped you, and how there could be a spiritual aspect to that, whatever that may be, depending on the individual interpretation of spiritual.
I think that there's not enough latitude, and this is certainly a point that I think everybody knows, not enough latitude in the current service system to respect all ways of recovery. How you get there is up to you. I mean, and if you get there, honestly, I don't think we do a good enough job of allowing people the right to their own struggle. And I'm guilty of this too, get stuck in this fixer fixation where you just need to fix all the problems. And I think that does blind us to alternative ways of recovery. I've experienced that myself. I was born and raised Irish Catholic, and while it's not a part of my life anymore, it was something that contributed a lot to my recovery at the time. And probably informed some of my worldview, although I don't take this position out of any particular religious stance. But, I think that we need to be able to appreciate solid research behind this too, that people who are part of religious communities tend to recover better and faster than people who aren't, or any other kind of community where they're interconnected with others. And that speaks to the point that hospitals are great to help get people on the path to recovery, but people don't recover from mental illnesses in hospital. They recover in real life, in the community, with all the stresses and ugliness that includes, but being enabled to actually cope with that in a supported environment. And whether that's a religious community or something else, I think that's great if you have that.
I'm honestly not sure how to address the question, and I'm not even entirely sure what the question is. I mean, I think I can only comment on my own experience, which was that I think when I was in treatment, I more or less had access to spiritual support.
I think it's like
But-
we get to talk about death with in the first place. Like who's actually going to have a conversation about death with us if we're in the institution? Who's going to listen?
Well, yeah.
That's a good question.
That's probably going to be.
Because we do talk about suicide, but we're not allowed to talk about death or.
No.
What happens when you die, and how that doesn't just have to be for like a spiritual
Yeah.
person, but that those are just conversations that we can have anywhere.
I'm pretty sure that if I tried to have the conversation like that on a unit, that it would be regarded as a symptom.
But goes back to the point that you made earlier about the comfort of knowing that that is a choice, even if you don't use it. It actually goes, what's your name again? Sorry. It goes
Graham.
back to your point. It really actually does tie in. It's interesting. It's something that is helpful to discuss, if nothing else.
We got a couple more questions. It's 7:15. I think we're going to 7:30-ish. I just want to, again, plant some seeds of, do you want us to do another event like this? Think about what you want to next steps. Do you want the Empowerment Council to organize another forum? Not that we need more work, but just to keep that in mind.
Can I speak? Yes. Two things. People who make decisions about what avenues of treatment are going to get funded or not funded are conscious that they are spending other people's money. We are in a socialized medicine country, which is a good thing, but they are careful. They are guided by research, evaluations, probabilities. All of us, all our lives, can act only in terms of probabilities as we understand them. Second thing is, there are people who you can talk to about death no matter where you are or who you are. I am the president of the Right to Die Society of Canada. And for the past 15 years, I have been the ears, the voice, the face of talking about dying. I have gotten emails, phone calls in very large numbers from people who break my heart. And on behalf of them, I have written a paper which is technically available on the website of the Journal of Ethics in Mental Health, but they're having technical problems. At the moment, you can't read it on their website. I've printed 2 copies for Kevin before coming here. And if you want to send me an email, it's ruth@righttodie.ca. I will email you somehow or connect you to this paper, in which I make a lot of suggestions, one of them being the reason I applauded when someone said enough. I am proposing that we could have sort of, I hate to say cut off, but we could have a time when we said enough. If this person has tried, say, 10 or more different drugs, has tried therapies for 5 or more different years, has had courses of treatment, standard courses of treatment from, let's say, 5 or more different professionals, we would adjust the numbers eventually over time with experience. But it would take away this feeling of foreverness and doom that people now have.
I'd just like to answer this question that's up there, that yes, absolutely. I would want Canadians with mental illness to have access to MAiD. If nothing else, to give mental illness dignity that it sometimes is not there, at least in my community, where it is seen as something as a willful indulgence at best.
Hi, I'm the visitor from the UK, so hello. I guess my question is about given the validity to the voices of people with mental health needs. And I guess one of the ways I just want your thoughts about one of the ways to do that would be about using advanced decisions so that you could validitize people's opinions and voices over time. And I work in an advocacy service in Newcastle upon Tyne, and we spend a lot of time with service users, getting them to write down their advanced decisions. And we do, even though it's not legal in our country, we do find it helps people to be able to write that down and to make a point of view about that, even if they feel like it's not going to be realised. So my question was, what do you think about the role of advanced decisions in terms of amplifying people's voices and validity?
This is, certainly my thinking on this broader issue is anything but black and white, and I think this is one of those areas where there's a lot of gray. Especially when it comes to progressive conditions like dementia in particular. I mean, that's one of the easiest examples. My struggle with it, that while yes, I've firsthand observed people go through this struggle until the end of their life. That doesn't mean that just because they've lost capacity after a certain point with that dementia that they still can't change their mind. So that's my concern with advanced directives. I think it's a necessary conversation. It is a gray area, but my concern is that what happens if you change your mind after you lose capacity. In my own experience, I can also say that, and I've had this conversation with my wife several times, only half the time joking, that if I ever lose capacity, that if my condition ever becomes, and there's a good chance that it will, such that I can no longer make decisions for myself, what do we then do? How do I want to be treated moving forward? And what had always helped me was to always have somebody to tell me that I could do it when I didn't want to. It was somebody to compel me, I know that's a dirty word in a place like this, but to compel me to go another step further, especially when I didn't want to. So, that's part of my own little, I guess, living will of sorts in my own relationship, but that's respectfully a very personal decision as well.
The room is bubbling with questions as we're winding down. So Thomas and then Kenneth, because you haven't had a chance to speak. Thomas is right there.
So two things have struck me. One is the concept of is there room on the continuum for this as an option? And secondly, thinking about what you were talking about in terms of we as a CAMH community. CAMH will be coming to an understanding of a position organizationally on this issue, and will be advocating with the Council of Academies for a position. So whose viewpoint prevails in the organizational position that will then be put forward as one of the leading organizations in the nation advocating for a particular position? Is there room on the continuum for CAMH to say, we're open to the notion, albeit with this set of reservations, or we as an organization are closed to the notion of it being an option for this population of people? Because the CAMH voice will bear weight in the national considerations of whether or not it gets expanded. Whose voice prevails in forming the CAMH perspective, and why? And so I think in this context, that's something we need to be conscious of and consider when that position is reached. Is it a position of consensus, or is it a position of one particular point of view being superimposed on an entire community of people that may not necessarily have achieved consensus on that? So I think this is an opportunity. As a community, we've come together to talk about it and think about where will CAMH land.
Can I make a really radical suggestion? It's a bit flippant, but not entirely.
And I'm not suggesting where it should land. I'm just saying, is this something we need to...
Understood. What if CAMH were to say, we're going to leave it up to the service users to decide? Like, we're talking about whose voices are privileged in this conversation. Why don't you say, we're going to let the service users' voices come to the forefront in this one? What would that take? Because it makes me see a bit double the idea that this organization, which has done a lot of good and a lot of damage, automatically has a powerful seat at the table that my people don't have. Like, it makes no sense to me whatsoever.
So what would it take for the organization to give you a seat at the table? Is it this event and more like it?
No. That's not the proposal. The proposal is for CAMH itself to say we're going to take a step back, and we're going to allow the voices of service users through their organizations to step forward and make this recommendation. It's not ours to say.
So the service users in the room are like, here. The professionals in the room, brains are exploding. But that's okay. We're at sea together. We'll keep rolling.
I want to thank Lucy and organizers for having this dialogue and the panelists. Lots of important and points that can be made, and appreciate all your thoughts. So I think I can, there are lots of things I can say, but I don't want to hog up the time, but I'm curious about what particularly the last two speakers are thinking, what would be the next steps, because currently there's nothing to prevent mental illness as accessing MAiD, but for that criteria of basically imminent death. So to move it forward, according to the last two speakers' wishes, would it be to remove that as a criteria entirely, so that that's no longer in the criteria in order to enable people with mental illness to have access? Or is it to categorize mental illness differently, to say if you have a physical illness, you must die soon, but if it's a mental illness, that's not a criteria, which would try to make a distinction between the suffering from mental illness versus, let's say, suffering if you had a stroke and you can't walk and you don't like this life without walking. It's not going to kill you, but I'd rather die than to live with a life, half paralyzed or not having the use of my arm. So just curious about what the thoughts are.
I would think that of the two options given, the best one would be simply to remove the requirement for the reasons you said, someone who has had a stroke and is unable to walk anymore and doesn't want to live that way. Because it just seems to me that people's lives are their own, and we're talking about giving people the power to take their own lives, basically. We're saying that, and one of the arguments that I mentioned before that pisses me off is that mentally ill people don't have the rationality, the informed consent to make this decision over their own lives. But it seems to me that there are a lot of irrational people making a lot of decisions affecting a lot of people's lives, and no one's asking them about it. But I think it comes down to, for me, it all just comes down to a sort of simple analogy, which is that if you go, and it doesn't matter whether you have a physical ailment or a mental illness, if you go see a show and by the intermission you have determined that this show sucks, I fail to see why you should be compelled to see the second act. You should be able to walk out.
My thought on that is something that I kind of alluded to in my talk, which is that I think that it is safe to say that in many cases death is predictable. It's just a question of what's causing the death. Is it the body that's failing, or is it the mind? And like I say, my death would have been fully predictable, and that's the only reason that OHIP paid for me to go to Boston for treatment, because it was clear. I made it abundantly clear that I would be dead. So, I'm one of the rare people in that I actually went through, and I'm kind of a poster child for OCD recovery. I'm like in the very small statistics of people who go through something, what I did, and then come out as good as I did. But I still feel very strongly that I want to reserve the right to die, because mental illness has been a part of my life off and on. It's entirely possible that it may come back, and I may not be able to beat it again. So the question, when I think of all the people who have died in my life, all the people who have died by suicide, not many of these deaths were actually surprises. A lot of them made it clear through previous suicide attempts and through conversation that they were going to kill themselves. So I don't personally think I mean, we even start to use the language now, so-and-so lost their battle to psychosis, so-and-so lost their battle to bipolar disorder, they were taken by OCD, depression, depression took their life. Well, that's not just rhetoric. If I mean, not that I entirely buy into the medical model, but if it's predictable that I'm going to end my life with or without the help of the medical community, then to me it's a question of harm reduction, really. And I don't think it's very different from saying I'm going to suffocate to death because I've got some illness that's progressing my paralysis. It's going to prevent me from being able to breathe. It's predictable. Well, it can also be predictable that I'm going to kill myself. It can be entirely predictable. So I think it's an understanding of what's the cause of the death. Does that matter?
That predictability, I think, it's a really important point, because that's what underpins the scandal that we're facing in Canada right now. That more than or almost 4,000 Canadians a year are dying by suicide, and most of them, all of them, we can stop from doing that. We can help them to live. We know the treatment works if they can get the help that they need. These people who are dying, these 4,000 Canadians a year, they're not sitting down with a list of pros and cons of life or death, or most of the time they're suffering. That suffering, just because it's not being remediated, doesn't mean that it's irremediable, however. They don't have to be suffering, and that's the scandal, I think.
I kind of disagree with that point, actually. I don't think it's possible to save all 4,000 people, because very often the answer to someone trying to save my life if I want to kill myself is to lock me up in a little room and shoot me full of drugs, and that makes me worse, not better.
No, and that's not the way we prevent suicide.
No, but that's, and it's not, I recognize that you're talking about something that's bigger and holistic, but anyway, I don't want to say anything further.
It's 7:30. I'm going to take maybe 2 more questions. People can stay behind if they want to chat a bit more, but it is getting hot. We tried to open the door. There's a question at the back, and I'm going to go with that person because I saw it next.
Microphone. So I certainly won't try and speak on behalf of anyone but myself. My experience with the mental health system in Ontario, my 2 biggest problems with it is that it seems to be far more reactive than proactive or preventative. It's not until I'm in crisis that I'm being told, here, take a pill, you're going to be like this the rest of your life. All these limitations are put on me. It's a horrible way to live. The other thing that I find is that having gone through the system for the last 19 years, it was incredibly disempowering, and it doesn't have to be. And it wasn't until about 1.5 years ago when I became a client at CMHA and I started working with social workers that things started to turn around for me. And that CMHA and other community mental health organizations are fighting for funding. That there's not enough, that people are on waiting lists for months or years to get, services that are known, proven to be effective, and to help prevent someone get to that point where they want to die. To me, that goes beyond negligent, it's criminal. And for me, and it was something I believe, Mark, that you had said, having the option to die makes it easier to live, and I do believe that. I no longer want to die. I haven't wanted to die for 1.5 years. But I do believe that I have the fundamental right to choose whether I'm going to live or die. And if I choose to die, that I can do so with dignity in a way that will not further traumatize my family and my friends. And I think that having the option to create an exit strategy, even if I choose never to use it, knowing that it's there gives me some of that power back. It gives me that choice, and it validates that I do have the ability to think and to choose and to feel.
Thank you. Okay. Oh, you need a microphone. I'm going to try to squeeze 2, so I'll do you and then you quickly.
Thank you. Really, mine is a comment. As I'm listening to these really great discussions, and Lisa, you
brought it up was I haven't heard all the voices. We haven't heard all the voices on this, and I'm thinking in particular about people of color, Black people in particular, who deal with mental health issues and are at risk of being shot by police for their mental health issues. So does that change the conversation? And I'm thinking about Indigenous folks who talk about cultural genocide over the years in Canada and their relationship with mental health issues and the systems. Does that change this conversation in some way? And so I envision, you asked, what would the next step be? I'd love to see a panel specifically centering those voices that we don't often hear about, and what does it bring to this issue?
That sort of goes into what I was saying. I wanted to say a couple of things. First of all, I think we're, and I'm not a liberal, but we're rather fortunate to have Justin Trudeau as our Prime Minister right now, because his mother has a mental illness. So he actually has a real understanding in depth of what it's like to live with someone with a mental illness. So we're fortunate in that way, and that perhaps that can help us to, I'm not quite sure what I want to say, but you know what I mean, like we have somebody who understands what's going on. And then the second thing was what I wanted to say as well, that I really would like this to be something that we now continue with in some way. And I love your idea of having a panel of people with color, Indigenous people, as being the next step. I think that's a great idea.
Great. Thank you. So I've got that great suggestion, and then the other suggestion is tell CAMH, leave it to the service users. So we do have a seat at the working group, so I will bring that up. I think we'll wrap up now, if that's okay. People could stay behind if they want to chat some more, of course, grab some more food. First, I wanted to thank the audience. I was very nervous about how this was going to go and what was going to happen in the room, but I really, really appreciate how respectful everybody has been and how open. I cannot thank you guys enough for coming in and speaking. These guys were great.